Hello, Frederick. Just confirm if you can hear me.
Yes, we can hear you.
Thank you so much. Thank you, Frederick, and thank you everyone for creating time to join this webinar. I really want to thank Laboratory Medicine Society of Kenya for giving me this opportunity to have this discussion with my fellow colleagues across the country. I really wish to welcome you to the day's talk, and it will be an interesting talk, which is basically an interactive talk that I expect that all of us should be able to join in and add their expertise and their experiences in terms of kidney function and how we as laboratorians usually assist in trying to look at how we can help patients or the clinical team to manage kidney diseases. So as already mentioned by Frederick, my name's is Peter Kibet Kiptim. I'm a practicing medical laboratory. I work at Kenyatta National Hospital in the Department of Laboratory Medicine, Clinical Chemistry section, where I lead a team of scientists, stroke MLOs. I also wear another feather. I'm also the chair of the Clinical Chemist Association of Kenya. Probably some of you are hearing this association for the first time. So probably in the near future, we shall be interacting more about our association. So right away, I think my topic as already mentioned, I'm just going to talk about biomarkers of kidney function and their clinical utility. Just to start us off, across the world every month, I'm sure there's something that is always celebrated. Father's Day, Mother's Day, whatever kind of celebration. But for kidney specifically, during the month of March every year, we do celebrate World Kidney Day. And this year, the World Kidney Day took place in the 13th of March, 2025. Interestingly, during this, the rally on call, or what was being talked about as the theme for this year's World Kidney Days, was the question that was being posed: are your kidneys okay? And the rider was detect early, basically to protect kidney health. So detection early squarely lies in our profession, because we are part of who aid to detect the kidney early. Any kidney condition to be detected early requires us as the laboratory as part of the diagnostic workup. So interestingly, during this topic, the objective that I intend to achieve during this talk is that basically we will review the functions of the kidney, just to remind ourselves what are actually the functions of the kidney and a brief physiology on how the kidney works. Then we will briefly describe the global picture of the kidney disease burden. I will also tackle or describe the current kidney function biomarkers that are in use. I will mention basically 3 of them in brief, and then I will describe the new biomarkers, the potential biomarkers, and those that we are being advised to implement in practice. So just to start us off is the introduction. Basically, as we can look at the anatomy, kidneys are bean-shaped organs, and they are approximately 10 by 5 centimeters big. They usually describe it as is the size of your fist, basically. And on cross-section, you will find that it has 2 distinct areas, the cortex and the renal medulla, which is the inner area. And within these 2 sections, we have the nephrons. The nephrons are usually the key to the kidney, because they are the functional unit of the kidney. And these usually span between the 2 layers, the cortex and the medulla. On average, your kidney weighs between 150 grams for males and 135 grams for female. And this is quite deceiving because if you look at the weight of a kidney, 150 grams is a very small weight compared, for example, if you're a standard man weighing around 70 kgs versus your kidney, which is 150 grams times 2, that's about 300 grams. But if you look at the weight of the work that the kidney does, it has tremendous work for keeping you alive. So once you lose a kidney, then everything shuts. So you're just trying to compare the weight of the kidney vis-a-vis your body weight. Then you will see that it is small but has a very huge effect to your daily living or your physiology of your body. If you look at the kidney function, I've already said that the functional unit of a kidney is usually the nephron. And each kidney is made of about 1 million, approximately 1 million nephrons. So if your two kidneys, on average, you have 2 million nephrons. And each nephron usually has two parts. It has a glomerulus and it has a tubule. That is the proximal PCT, the proximal tubule, and the distal tubule and the loop of Henle. The nephrons works by basically two steps. The first one is the glomerulus, where the blood comes in and it's, the filtration is happening. And then the tubule is where the reabsorption and secretion of substances happens. And finally, it goes to the collecting duct. And now you have your urine. Basically, this is how the kidney looks like. And as you can see, there are two distinct areas, the cortex. So once you zoom in, you will see the nephron itself, and we have the glomerulus, which is usually at the Bowman's capsule. So blood comes in, the filtration starts at the glomerulus. Then we go to the proximal, the PCT, the proximal convoluted tubule. Then it runs down the loop of Henle. Then we go back to the distal convoluted tubule, and then we go to the collecting duct, and you have your urine, and basically your blood will be filtered. What goes back to circulation is blood without waste. Importantly to know that there's a lot of pressures and a lot of dynamics that happens at the glomerulus. So there are those substances that are allowed to be filtered through, especially based on their molecular weight. And there are those ones that are not filtered fully. Once they are filtered because of their molecular weight, anything that is useful, the body is reabsorbed at the proximal convoluted tubule back to circulation. Then the loop of Henle basically does to balance whatever is required to be returned back to the to circulation and what needs to be excreted. So basically, that's how the kidney works, and that's the basic physiology of a kidney. Basically, if we go to the functions of the kidney, there are quite many, but the kidney does have basically an endocrine function and an exocrine function. The exocrine function is just the production of urine, but if you look at the endocrine function of the kidney is responsible for producing certain hormones. We could be aware of erythropoietin. Erythropoietin is useful in production of red blood cells. So the kidney is the sole producer of erythropoietin. And there's a discussion towards it because it controls also the blood volumes, because once it controls the blood volumes, it enhances the production of erythropoietin, which goes ahead to increase the production of red blood cells. Also, on the endocrine function, the kidney also produces an hormone called renin. Renin is involved in the RAS system, the renin-angiotensin-aldosterone system, which basically helps to control your blood pressure. So the kidney plays a big role in the RAS system. That's why it's able to control your blood pressure. We are also aware that the kidney is the active site where vitamin D is activated. So one of the hormones is calcitriol. I don't know, I know it's a bit debatable whether vitamin D is a hormone or a vitamin per se, but mostly it is classified as an hormone. Of course, the kidney also does metabolic waste excretion. Any waste that comes up after your metabolism is excreted through the kidney. The kidney is also able to do drug metabolism, though it's not the primary site for drug metabolism, but it supports the liver also. Some drugs are metabolized in the kidney. And of course, if it is metabolized in the liver also, it is excreted through the kidney. The kidney also plays a big role in acid-base balance, basically maintain your body pH, and this is by basically controlling the hydrocarbonate and hydrogen ions, either by excreting them or reabsorbing them to make sure that your acid-base balance is kept at the physiological range. Of course, I've already mentioned that it controls your blood pressure. And it maintains solutes and fluids. Basically, this is maintaining the salt balance, and this is controlled by by looking at the osmolarity. And if your osmolarity goes low, then we are able to retain more fluid so that we balance. Osmolarity basically is the tonicity of your blood, because we know if your blood becomes hyperosmolar, then you lose fluids, you crease your cells, and your cells might die. So it must be at an equilibrium so that you can maintain your body functions. So basically, in summary, fluid balance is what the kidney will do for you. It will maintain your blood pressure, it will do the filtration, it will help you have your red blood cells, it will help maintain bone health, and basically this is because of vitamin D, because of the control of calcium. So basically it maintains your body, your bone health. And of course, maintain balances, especially acid-base balance. It will always maintain your acid-base balance because of controlling the hydrogen ion and the bicarbonate. If you look at the kidney disease, these are diseases, is a variety of disease conditions. So it can be either malformation and runs through to other disorders that affect the kidney. So all of them in totality are referred as kidney disorders. And since we've said that the functional unit of the kidney is the nephron, so most of these kidney diseases will affect the nephron. And the main forms of kidney diseases are four. We start with the acute kidney injury, then if that persists, you go to acute kidney disease, then chronic kidney disease, and then finally you go to end-stage kidney disease. Once you reach the end-stage kidney disease, there's nothing else we can do other than maintaining a dialysis, or you get therapy that is basically kidney transplant. And it is importantly to underline at this point that the GFR, which is the glomerular filtration rate, is the true measure of kidney function. So for us to measure kidney function, we have to do the GFR. So how do we define kidney diseases? I'm just looking at this paper that was published some time back. So as I've already mentioned, there are three stages of, there are four, but we will define the three of them. One of them is acute kidney injury. And to define acute kidney injury, you have to meet the following criteria. So either your serum creatinine increases by 50% within 7 days, and 50% is when we have a basal creatinine, then we monitor for 7 days. So if you are from the basal, you increase by 50%, then we would say you are having acute kidney injury. If your serum creatinine increases by 0.3 milligrams per DL, this is not the this is the conventional way of reporting creatinine, which we don't do here in this country. We do it in millimoles per liter. But where I borrow this pictorial is what they use, the conventional units. And if you do the local units, it will be around 26.3. millimoles per liter. So if you have a creatinine increasing by that value within 48 hours, then we would say you're having acute kidney injury. Or you have an oliguria, you're unable to pass urine for more than 6 hours, then you're probably having a kidney injury. So if you meet any of those criteria, we tell you that you have acute kidney injury. The boundary is 7 days. Once you are past 7 days, then you move to the next stage of kidney disease, which is acute kidney disease. And by definition, is your GFR is now lower than 60 ml per minute per 1.73 meters squared, or you have a GFR decline of more than 35%, or your serum creatinine has increased more than 50%, then you are at acute kidney disease. But this persists for 90 days and more, then you go to chronic kidney disease. And you're going to attain any of the 4 definitions that you already mentioned, and mostly we look at your GFR going below 60 ml per minute per 1.73 meters squared. So basically, as you see on top, at every point at AKI, you can always recover, or unfortunately, we can lose a life. And once you reach CKD, you can progress now to end-stage kidney disease. So at these 3 stages, the recovery is still possible. But it's never that simple, because kidney damage and kidney injury is not as straightforward as it is, because we've already seen that it's a continuum. It's not like a one-off thing. It's something that happens. And before you reach this, you must remember that the kidney also has a very good kidney reserve. Before your serum creatinine increases by 50%, most of the time you have really lost a number of your nephrons. So this pictorial here is just trying to show you that there are areas like when you can have a damage without loss of function, you can have no damage, you can have no functional changes or damage, you can have loss of function without damage, you can have damage with loss of function, and they oscillate from any other window from another one. But the worst is when you have a damage with a loss of function. So basically, it can resolve anytime, and you can progress at any time. So it's a very complex pathophysiological process, and why it's important that we discuss about kidney diseases and our role of capturing this transition from damage or injury to loss of function. So what are the risk factors? Basically, for acute kidney injury, the risk factors are usually when you have a very recent infection, when you are using certain medication, especially the ones that are metabolized in the kidney. And we've looked at some, like gentamicin, I think is one of the drugs that have an impact in the kidney. Some of the antibiotic, basically, that's how I would mention. If you have severe dehydration, then you're at risk of having experiencing an AKI. And if you are exposed to heavy metals and toxic solvents, industrial solvents, then you are at risk of having acute kidney injury. Again, when you have a massive blood loss, or it will take you to shock, and most of the time you have an acute kidney injury. As you might remember, that the kidney receives about 20% of the cardiac output every time your cardiac output is there. Your kidney will receive about 20% of that. So once your blood loss goes down, then probably you will suffer with AKI. And most of the time when you see like in road accidents or where there's a lot of loss of blood, most of the time these patients are undergoing an AKI. We look at chronic kidney disease. I think this is very important because most of the non-communicable diseases will always put you at risk to chronic kidney disease, especially diabetes, high blood pressure, cardiovascular conditions, obesity, tobacco use, and your age. As you age also, your GFR reduces and you are at high risk of developing CKD. As you can see, most of these things are very modifiable. And that's the reason why we need to really monitor. If you are obese, you need to monitor. If you have diabetes, you need to monitor. If you have high blood pressure, you need to monitor your kidneys very closely. And that's the reason why most of the support system we do for these patients is that most of the time they come to the clinic, you will see clinicians requesting for renal function tests. If you look at the global picture of kidney disease, I'll just borrow from this paper, which is a consensus statement that was published, I think, in 2024, and it's an increasing global problem, and it's associated with high individual healthcare and societal cost. We all know what it takes to get dialysis, where you have to go for 2 sessions probably in a week, and what that means in terms of cost once you hit the end-stage renal disease. That about 850 million individuals are affected globally, and the estimate is that the global prevalence is above 10%. But this prevalence is just an estimate because it is assumed that across the world there is a gap in screening programs in the world. So what we are simulating with 10% is basically an approximate. Most importantly, you need to note that acute kidney injury affects about 7 to 18% of hospitalized patients. And if you are working in a facility that has an inpatient facility, mostly patients in critical conditions will always have a series of AKI. So it is very important to note that this is a very huge percentage of patients who are in the hospital suffer an episode of acute kidney injury. Just importantly is to note that most of the people who are affected by AKI live in the low-income countries and also middle-income countries, where basically our country falls into. Talk about a biomarker. We can just basically define what a biomarker is so that we can appreciate as we move along. So a biomarker is a characteristic that can be objectively measured and evaluated as an indicator of a normal biological process, a pathological process, or a pharmacological response to a therapeutic intervention. So this is anything that you can measure objectively, and it can span for as simple as a body temperature through to a genetic test, as long as it is an indicator of a normal biological process, a pathogenic process, or a pharmacological response to a therapeutic intervention. So that's the standard definition of a biomarker. And biomarkers are classified under 3 main broad terms. So it can be either genetic or molecular. The first category is usually used in clinical trials, but we will look more on the characteristic, and I will go straight to the molecular biomarkers, where we have chemical biomarkers, genetic biomarkers, and protein biomarkers. So what we'll be looking at mostly today will be chemical and protein biomarkers. But again, by use of clinical applications, we can say that either this chemical biomarker is a diagnostic biomarker, or a prognostic biomarker, or a therapeutic biomarker, based on how it is applied in clinical practice. So what would be the characteristic in reference to renal kidney function? It should be something that is easy to measure with the validated reproducible technologies. I know we as laboratory professionals, we know how to speak about a valid method. So any biomarker should be very easy to measure using these validated and reproducible technologies. It should be stable in either blood or urine. And of course, this is the reason why once you draw your blood, that biomarker should be stable, because if it's labile, then you probably will not be able to get the measure of it. It should be free of interferences because of matrix effect. it should be unaffected by the chemical composition, basically of the fluid, especially if it is in urine. If you look at the pH and there's a specific gravity, then it should be able to reflect the risk, injury, outcome, and chronic sequela of the disease, and it should have high sensitivity and high sensitivity. Here we are talking of the diagnostic probably. It should have, if you're looking at a diagnostic biomarker, it should have high sensitivity and high specificity so that you can be able to pick up what you want to pick it up for. Then changes in measurement of this biomarker should reflect an efficacy of an intervention or recovery. So if you have a baseline, it should be able to show you as you make a follow-up, that biomarker should be able to reflect that the intervention is working or a person is heading towards recovery. Then it should be able to identify the specific site of the injury. Like we looked at the nephron, it should be able to tell us if the glomerulus is affected, or if the tubule is affected, or any other parts in the anatomy of the kidney. And it should be something that is understandable in terms of function in the kidney. What does it do actually in the kidney? Importantly to say, most of the biomarkers that we have cannot meet all these requirements, but there are some that are met by one biomarker and the other one cannot meet. So it is usually advised that you combine more than one biomarker to ensure that you get the good picture about the performance of that biomarker. So if we look on how we apply our biomarkers in kidney function, so we've already mentioned that kidney disease is usually a continuum from a normal kidney to kidney failure and probably to the unfortunate event of death. So it is a time process. So we can have biomarkers that identify susceptibility. We can have biomarkers that identify injury. We can have biomarkers that are used for diagnosis. And then we can have biomarkers that are used for staging and tracking the progression of the disease, basically. As you see this figure, where we have currently is what we do in the lab is usually we look at where the oval circle is the functional markers, where we look at the GFR. But there is a proposal to expand the diagnostic practice, where we also include the damage markers. So the reason why there's a lot of work in biomarker discovery is because we want to come to look at the damages so that we can arrest whatever is happening early enough than to wait until the GFR is very low. And as I've mentioned earlier, is that the kidney has a very good reserve. So before your GFR goes very low, then it means you've lost almost 50% of your kidney function. So if we look at the legacy kidney biomarkers, we all know that the two samples that usually come to your lab are either a urine or a blood sample. And the most measured one is usually the serum creatinine, followed by blood urea nitrogen. I know this term is not is used interchangeably with urea, so you might wonder why I say urea, blood urea nitrogen. So basically, blood urea nitrogen was applied mostly in the US because they were using whole blood years back to measure the urea nitrogen within the whole blood. Then we have urinary albumin or protein, but basically what we need to look at mostly is urine albumin. We also have urine volume excretion is one of the criteria, but it's sometimes very difficult to use in the clinical setting. Then we have the electrolytes. The electrolytes, are usually very supportive just to see on how the kidney is functioning, but they are not at the core of the kidney function. So basically the first two, the serum creatinine, is usually what guides to see how your kidney is performing. But just putting the bigger picture to look at your electrolytes, then if your serum creatinine is affected, then you will see there's also an effect of performance of your electrolytes. I know some of us add other ions, electrolytes, that's calcium inorganic phosphate and magnesium in your UEC panel, or you're doing them probably as a panel for electrolytes alone. Urea is included. It's also part of the kidney function, but the specificity is not very good. So proceeding from here, I'll just talk about the basic one, which is serum creatinine, urine albumin, and one of the biomarkers. So serum creatinine is one of the most requested tests. I'm sure if you work in a chemistry lab, I know you've done a couple of them since morning. And it's also used to estimate the GFR in the laboratory. Just to recap is that there are two main methods for measuring creatinine. The Jaffe method was the initial one, and it has undergone a number of modifications. Then in sometimes later, because of the challenges that Jaffe method had, there was an enzymatic method came up, and most of the literature now advocate for you to use the enzymatic method because it has a very low variability of about 2%, I think, compared with Jaffe, which is about 5%. And it is important to know that the imprecision of serum creatinine has improved over the years, especially from Jaffe's original reaction up to now, because of every other time there's always improvement. And one of the improvement was, of course, standardization of creatinine, the creatinine by standardization of the creatinine method by the manufacturers. So it is also important that to note that the serum creatinine that we use has its own physiological limitations. And this is the reason why sometimes it's not a very reliable marker, but since it's the one we have, we use, but we must be cognizant of the fact that there are some non-GFR limitations. And of course, there are physiological limitations and also analytical limitations. And if you look at the physiological, you would have an increased serum creatinine, especially if you had a red meat diet, if you are having creatine supplementation, especially for those who are doing bodybuilding. If you have greater lean mass, if you have good muscles, then your creatinine will be higher. Then if you have taking some medication that prevent the excretion of creatinine, then your creatinine will go up. So once they go up, when you see it in the lab, probably you might think this person is having kidney failure, but it's not because of the kidney failure, but it's because of the physiology of something which is non-renal related. Also, you will have a decreased creatinine levels, especially because of the degradation by gut microbiota. For older patients, of course, we'll have lower creatinine. And also, if you have nutritional deficiencies or if you have cachexia, especially when you have conditions like cancer, we know you lose your body weight a lot and then have a decrease in serum creatinine when you test it in the lab. The other marker is cystatin C, and cystatin C basically is a low molecular weight protein. It is freely filtered at the glomerulus and metabolized at the PCT, and it's not excreted, so it is metabolized fully. So you don't expect to get serum cystatin C in your. It is also affected by non-GFR factors, but it has been seen that cystatin C is not affected as much as creatinine is affected. So it is a very promising, and it is advocated that it's a better marker for GFR estimation. And just to look at the physiological limitations of cystatin C, of course, renal dysfunction will always increase the serum cystatin C, but importantly, also, we don't know the effect of genetic factors, but inflammation, especially C-reactive proteins, will also increase cystatin C, and we don't know about cystatin C also having an impact in negating cathepsin production. But most importantly, you look at obesity, aging, hypertension, dyslipidemia, metabolic syndrome, and heart failure. These are risk factors for CKD, and it is questionable whether these risk factors are increasing cystatin C. So I think this is one of the major things that we need to know. I've not seen a paper that has investigated the impact, probably like obesity in cystatin C, but it is important to note that these are putative things that are thought to increase the concentration of cystatin C. The other biomarker that we look at is urinary albumin, and it's important also in detection of kidney disease. But we have an issue with, we have challenges because of standardization of urine albumin measurement. And the main key point is because we have multiple test options, either to do albumin or albumin to creatinine ratio. There's always a confusion whether to use, which type of sample to use, whether random, timed, overnight, or a 24-hour urine. There is no international reference material or a standard for albumin measurement, and there is no standard reporting units, standardized reporting units, and there is always an arbitrary cutoff of 30 milligrams per gram, and this is for both ages and sex. So, as much as urine albumin is a very good marker, and even when we are grading CKD, we also use urine albumin, but it faces its own challenges, as you can see. But in 2018, Greg Miller and his colleague from ADLM gave at least how we should guide measuring. So they recommended that when you are doing albumin, urine albumin, we should call it urine albumin instead of calling it microalbumin, because the argument is that microalbumin is not actually something that can be measured, but it is the presence of albumin in urine, a small albumin. So the terminology that always should be used is urine albumin. And it should not be reported as a concentration, that is milligrams per DL or milligrams per liter, but rather be reported as creatinine ratio or ACR, and that should be reported either in milligrams per grams or milligrams per mole. So basically, that's how we can utilize microalbumin. But as I've already mentioned, GFR is the real measure of a kidney function. And sorry, this is a bit of a busy slide, just to show the narrative on where we started with the GFR equation. So back in 1957, we started with serum creatinine. Then the first equation was the Cockcroft and Gold. Then there was a MDRD version 1. Then we went to MDRD without standardized creatinine. Then there was a MDRD with standardized creatinine. Then from 2009, CKD-AP came up, and from there we've moved with CKD-AP. In 2012, there was the first eGFR equation using cystatin C. Then we combined cystatin C and serum creatinine. Then in 2021, which is the latest, we have eGFR for equation for cystatin C and a combined for both cystatin C and serum creatinine. Importantly, what you need to note is that race has been a big issue in medical equations. And as you can see in 2012, the combined formula had race aspect, but now in 2021, race was totally removed. And if you look at literature, there's a lot of debate why race, because they say race is nothing biological but social, so you can't put it in a biological formula. There's this paper that looked at eGFR and the 3 questions, and as you can see, in terms of bias, the best performing one was eGFR cystatin alone. And when you look at accuracy, the best that you would expect to have, both either you're using at black participant or non-black, if we are looking at race, the best is when you use a combined eGFR equation, that is eGFR creatinine cystatin C. So you can see this is something that has already been done, and you can see out of the 3 formulas, that are the CKD epi formulas, then you can see the best formula that you can use. Again, just to come back where we can utilize these biomarkers. As you can see, we've already said that your nephrons are usually about 2 million if you have 2 active kidneys. But with time, there is always a decline. And you can see where we can start using biomarkers when there's a decline in renal function. Because by the time you are having an incident of CKD, that is a GFR of 60, already you've lost about you're having less than 1 million active nephrons. And then, of course, as you go down, you're losing more nephrons, then you go to end-stage renal disease. So there's always a delay in diagnosis here at this point, because where the GFR is dropping is where we start, and already we've lost a lot. So biomarkers can really come in this diagnostic window so that we can capture renal disease early enough so that we can be able to prevent anyone going to end-stage renal disease. This is what it's more of like a speedometer, if you look at it, and it's just telling us to know our numbers. So if you are having an eGFR between 120 and 60, that is very normal. Anytime you hit 60, then you go to the yellow zone, and this yellow zone is where we say you have a kidney disease, which can either be an AKI, it can be a AKD or CKD. But once your eGFR goes below 15, then we already have kidney failure. And at the red zone, there's nothing much that can be done. The only thing that can be done there is just replacement therapy, that is kidney transplant, or you are maintained using dialysis. So the kidney disease has been a very active area in biomarkers. As you can see in this slide, there are a lot of biomarkers that have been worked on in terms of trying to get the best biomarker. And as you can see, I will just mention, if you look at the glomerulars, we have creatinine and cystatin C. These two are already validated. They are already standardized, more or less. And they are the ones that are used to do GFR, as you have just mentioned. But most importantly, if you look at the PCT, the last two, I know these are, they have already got, there's a kit which has these in combination. It's called NephroCheck. It's already FDA approved. It is available in the market, especially at point of care, and usually tested in renal. But another one which is very promising is KIM1 on top of that list. And also there's this one called NGAL. NGAL in full is neutrophil gelatinase associated lipocalin. And in short, it's usually called a lipocalin. And if you look at lipocalin, it can identify injury at the PCT, at the TCT. It cuts across the two functions of the kidney. So cystatin C also is a good marker, because you can see it rises earlier. It can tell us if there's an issue at the PCT. It can, and it can also tell us if there's an issue at the glomerulars. But these things are not very alien. Back in 2019, we did, I together with my supervisors did some work using NGAL. And we did NGAL basically in critically ill children. This is just an excerpt from a poster that we presented back in 2022. We enrolled 40 children in this study that were admitted, and we used KDIGO creatinine-based criteria to diagnose AKI. Interestingly, we found that AKI urine NGAL was able to capture 100%. 100%, or actually, it had a sensitivity of 100% and a specificity of 16%. plasma NGAL had a sensitivity of 85.7 and a specificity of 13%. And we felt that we looked at it, and the conclusion that we made from this study is that plasma and urine NGAL show very high sensitivity for early detection of AKI in critically ill children. And the specificity is low when it's measured against creatinine, because we were using creatinine as the gold standard. And we concluded that the performance of NGAL indicates that it can be used to screen for this patient, especially critically ill children. As you remember, we had already mentioned that most of the patients in the hospital suffer AKI. And I've not mentioned here that when we looked at urine NGAL, it was giving us a prevalence of about 90%. So 90% had AKI, but when we looked at creatinine, I think was giving us a prevalence of about 26%. So this basically means that creatinine sometimes is not able to capture these. And you know, kids, it's a challenge, especially for pediatric population when we are looking at using creatinine as a marker of kidney function because of the non-physiological factors that come in. So just to note, this time when we were doing this study, I think we were using a Jaffe method for creatinine. And I know improvement have happened along the line, so it would be interesting to see if we can replicate this study at this time. We see what kind of results we might get. So as I sum up my talk, this is the most recent KDIGO guidelines, and just I'll take you to the basic practice point 1.2.3.2, where it says, given available resources, clinical laboratory may consider the possibility of measuring both creatinine and cystatin C, either as in-house or as a referred test. So importantly also, there's something that is mentioned in this table. I think it's point number 3. Was it point number 3? I think. No, the point number 1 is that we should report eGFR in addition to serum concentration or filtration marker if you're using creatinine, using validated equation. That should be underlined. We should use validated equations. So as I started when I talked about World Kidney Day that we celebrated in March, and if you look at what they were advocating that time, the last point that was being advocated during this campaign is serum creatinine, in brackets, more accurate if in combination with cystatin C, to estimate eGFR and evaluate kidney function. So you can see we've reached a point where biomarkers are now being advocated more to be used in diagnosing or staging kidney function. But why are we not taking new biomarkers in practice? Of course, we have an issue of gold standard method. We are measuring our biomarkers with a gold standard in brackets, which is creatinine. And we know creatinine has its own inefficiencies, but even if we do what we do, we have to match it up with a gold standard, which is creatinine. So there's gaps there. There's undue conservatism in not believing that clinical studies inform the use and interpretation of biomarkers in man. Therapeutic developers have a reluctance to incorporate biomarkers in clinical trials. Diagnostic companies are not aggressive in developing biomarkers. And of course, there's the impact of harmonization of biomarker test values across lab sites, because probably what you are reporting in lab A and lab B are not matching. So there's still a big issue in harmonization of these biomarkers. So this is just a summary of why we have not adopted, but it doesn't mean that all is lost. I think we have brilliant people here and scientists who can take up this challenge and try to see, because it has taken a lot of time before cystatin C has come into clinical practice guidelines, but as you can see, is slowly being put in guidelines. So in the near future, we shall be having cystatin C as one of the markers that we are using in the laboratory. So in summary is that over the last decades, there has been intense interest in finding and qualifying new biomarkers for kidney injury. Biomarkers will enable us to diagnose kidney injury earlier and provide better information about status of ongoing injury in patients with CKD, as well as predict the likelihood of progression of the disease. And the bottom line is that this will facilitate personalized medicine in better informing interventional, diagnostic, and therapeutic decision-making to minimize kidney injury and optimize intervention strategies. I think that is the biggest goal that we want to see after looking at what the kidney, being a very small organ, and the impact it has to our health. I really want to stop there. I want to thank you for your attention. And just to mention again, I head this association called Clinical Chemistry, which is part of the African Federation of Clinical Chemistry, and which is part of the International Federation of Clinical Chemistry and Laboratory Medicine. Thank you so much for your attention. Back to you, Frederick, for moderation. Asante sana.
Thank you so much, Peter. Your presentation was great, excellently done. And you can see the comments from our members. Alfonso Chieng saying very informative presentation. Jacqueline Jebotip, very educative. Lois Ayuma, good presentation. Josta Karidi, very informative presentation. Brian Omondi, smart presentation indeed. So the feedback is overwhelming. And many of our members here have really enjoyed the presentation, myself included. Kurgat Tobias is saying, glad to see Peter. He has moved up the ranks. He was a junior staff at KNH in 2013 when I was a student on attachment. Thank you, Tobias, for the comments and for the kind words. And you can see that majority of our members here who have joined in have enjoyed. Paul Sairo is saying biochemistry at its peak. Keep wonderful teaching. Thank you so much. So Peter, there are a lot of many other comments that are appreciating this particular presentation. And also it has elicited a lot of questions. And I just want us to take a minute or a moment of the remaining time so that we can be able to just discuss. If that is okay with you, Peter. Peter, you can hear me?
Yeah, can you hear me?
Very well. So I'm saying we want to spend the remaining time to just get a few questions and comments regarding the presentation. And I will start with Leonard Bosco. Thank you, Senior, for the question. I saying, Peter, thanks for the presentation. What would you advise those in resource-limited settings, yet they have to still conduct kidney disease early diagnosis? You heard me, Peter?
Yes, I heard you, and thank you, my senior Bosco, for that very important question. Because at looking at kidney disease, the basic thing, if you are in a very low resource setting, is just a simple urinalysis. Though it has its own challenges, but a good screening, if you have a very good qualitative urinalysis kit, you can be able to pick some of these things. So urinalysis still remains at the basic, and once you identify that there's a problem, then you can easily help this patient to the next level of care. So that would be my advice. I think the basic is if you don't have any other resource, I think the urinalysis, even the strip analysis, should be able to give you a picture to how the kidney is performing, and you can easily capture that and then help this patient by cascading that to where you believe you can get more confirmatory tests for that matter. Thank you. Thank you so much, my senior.
Thank you, Senior Bosco, for that. So, Peter, there are a couple of more questions. I'll start with Ngeno Peter. Why is serum creatinine considered a delayed and a potentially unreliable marker in the early detection of acute kidney injury, that is AKI, and which alternative biomarkers can offer earlier and more specific diagnosis? Kindly explain their mechanism and clinical relevance. Peter, if you heard me, thank you, Ngeno,
Yes,
for the question.
I heard you loudly, Frederick, and thank you, Ngeno, for that good question. So basically, I think creatinine initially was felt that it was an unreliable marker, like I've already mentioned that with the time and with standardization of creatinine, there have been a lot of improvements. But the reason why creatinine is not performing very well is because it is known as a late marker. Before your creatinine rises to levels where you can say there's a kidney disease, you might probably you might have lost about 50% of your kidney function. Sorry, that's why it's a late marker. So it doesn't take the physiological before, and again you look at the renal reserve and how the glomerulus expels creatinine, and so most of the time you won't get that rise of creatinine early enough. Another thing is because we look at also the biological variation of creatinine, it has a higher biological variation. But again, I've already mentioned the physiological limitations of serum creatinine. So that's the reason why cystatin C is coming in, is one of the best marker, because when we talk about standardization, it's good that I've already mentioned even cystatin C, it doesn't mean that it is a perfect marker. And when I was talking about the characteristic of a good biomarker, I clearly mentioned that it is difficult to get a biomarker that can meet all the requirements. So most of the time, it is advisable that you use a combination, especially when you feel in that situation you are not able to rely on serum creatinine, then you need to have another biomarker to support the same, so that you're having them in a combination, so that there's a synergy where one is ineffective, the other one strengthens it. So you tend to get a more elaborate picture of the same. So Ngeno, I hope that answers. I know I cannot be able to really talk about how the rise and fall of these biomarkers but that is basically in a nutshell. Probably we can talk outside this, we can share more literature about other biomarkers and how best we can work. But I would say those are the two main biomarkers that we are looking at currently, because they are the ones that are already standardized, and we can see how best they can be put into clinical practice. Thank you so much.
Thank you, Peter. There are many questions here on GFR, and maybe I want to read them. Maybe you will see how to just capture them.
Okay,
so
sure.
Frederick is saying, what is the ideal sample for GFR? Second, what are the ranges for GFR? What does high GFR indicate? What does low GFR indicate? And what could be the corrective measures to have normal GFR? I think there are many. Maybe we can start with that.
Sure, I think it just talks about GFR in general. So the best sample for doing GFR, of course, is a blood sample, which is a serum sample for the excretion markers. I know there's always a debate whether GFR, okay, the best measure is to measure GFR, but in clinical setting, it's very difficult to measure GFR. So we usually use this equation to estimate GFR. And when we are reporting them, you will see a small e, so it's an estimated GFR. So we are estimating using filtration markers. And the filtration markers that we use here are endogenous markers. And the two endogenous markers that we have for filtration it's because of how kidney handles these two markers. One of them is creatinine, the other one is cystatin C. So once you have your blood, you do your creatinine, and then you use the formula, the validated formula, which is CKD-AP 2021. There are parameters that are used in the CKD, which takes the serum creatinine, it takes the age, and it takes the age, it takes the gender, it takes age, gender, and the serum creatinine, and then it will calculate for you. You can either use cystatin C alone, GFR marker, or you can use a combination of the two, depending on what filtration marker you have at hand. Once you do that, you should be able to go back to my speedometer. I hope I can go back to my speedometer. Yeah. So once you have that, you will just see high GFR. That is, so the cutoff is usually 60. And as you can see, it ranges between 0 to 120. If you have anything above 60, then your kidney function is normal. There's nothing you can do to increase it. It's just how the kidney function. But once your kidney function starts to decline, then your GFR start going down. And between 60 and 15, that's when we say you have a kidney disease. And at this point, it can either resolve or it can proceed to kidney failure. So a low GFR that is below 15, then you would be said that you are having kidney failure. And as I've already said, at kidney failure, the only intervention that can be taken at this point is either you are maintained on dialysis or you have a kidney transplant. Thank you. I hope I have, in a nutshell, tried to answer the couple of questions regarding eGFR.
Yeah, that
Back
is very
to you.
excellent. Sir.
Yeah.
Yeah, well answered. So maybe I can just bring in the others. So this is from Agri Mogire, how is cystatin C produced? And then maybe I can add more. From Emmanuel Wekesa, is it possible to calculate estimated GFR for persons under 18? Mostly when calculating it, it's recommended for 18 years and above. Also, kindly clarify the sensitivity of estimated GFR that's calculated online or electronically. Is it advisable or we have to use the manual one? Peter?
I think about cystatin C. So cystatin C is produced by, I think, all nucleated cells in the body. I don't know if I mentioned here. Yeah, I've mentioned that cystatin C is a 13 kDa low molecular weight protein that is produced constantly by all the nucleated cells in the cells, and then they go to the kidney, and then they are freely filtered and then metabolized. So it's a very constant rate. That's why we are using it as a filtration marker. I hope that answers for that. The other question was how do we know about the online GFR markers, calculators? I think they perform really well, and I would advise that you go to, is it NKF, National Kidney Foundation formula, because that's more reliable, because that is an association that is related to kidney practice. So the National Kidney Foundation formula, I believe, is a good formula. Then somebody asked, what about under 18s? As I concluded my talk, I said that we have a very big challenge, especially in pediatric population, in calculating GFR. There's only one formula. I think the current formula is the Schwartz formula. I think Schwartz formula is the one that we are using for eGFR. I cannot really authoritatively say if it is well validated, but that is the formula that we have for under 18. And basically, I think the reason also is because how we report GFR, we report under the 1.73 meters squared, which is the body surface area. And of course, you know, for pediatrics, sometimes the body surface area is very small. So at this point, what I can say is the Schwartz formula is the one that we use for the pediatric population. And creatinine also has a challenge when we are doing it for pediatric population. So basically, that's the best way I can talk about the pediatric population at this point, those who are under 18 years of age. I hope I've been able to tackle them. Fred, if there's none that I've not, maybe I missed, probably you would let me know.
Wonderfully answered. So we'll shift gears. I think there are many concerns, and maybe you can also see them on GFR. Still asking on the specific formula, which one is the most preferred, things like that. But I'm hoping we've been able to handle them. So Abel Kibet What is the association between uric acid and kidney function diagnosis? Should we use uric acid as one of the biomarkers for kidney disease? Okay, Abel,
Okay,
for the question.
thank you for that question. I know it's because the reason why uric acid most of the time is included is because uric acid is excreted through through urine. It could be a marker, but again, if you look at the sensitivity and the specificity of it, talking about renal function, it wouldn't. I don't think its sensitivity and specificity is very good at that point. So we can use it as a support, like I said, but probably because we are looking mostly at the nephron, then probably I think we stick to the two markers that I've talked about. But again, I can't really say that uric acid does not aid in looking at, but the only challenge would be its specificity and sensitivity in terms of looking at kidney function. Thank you.
Thank you. So I'll read two more. One is from an anonymous attendee. When do we start dialysis? And then the other one is from Alex Makoha. At 60 years and above, how often must one perform kidney function tests?
All right. I think somebody asked about when to start dialysis. Sorry, I don't. Okay, I'm not a clinician per se because that will be from a clinical side of view. But I know once your creatinine once your GFR is less than 60, I can't really tell which is the borderline to start dialysis. But I usually can't authoritatively say, but once you have a kidney disease, the clinicians will make a decision when to start dialysis, depending on other factors that they look at, and they will guide that when to start dialysis. But the most important thing is just to know that once your eGFR is less than 60, then you are having a kidney disease. Then, of course, it will. So our main goal here in the lab is to make sure that we are able to tell the clinician that this patient is having a kidney disease. Then from there, I think the other pathway of clinical care takes place, and then the decisions of doing that.
Thank you.
There's one question which probably I've not attended. I don't know what was it. I think I've missed it, but probably you can read the others.
Yeah, this is from John Mwanza. Kindly, can the presenter expound on insulin use in GFR and in its comparison with cystatin C? Okay.
It's not insulin, it's inulin. I think inulin is usually used when we are doing measured MGFR. And those are the kind of things that it's the gold standard, but it's very difficult to do in the clinical setting. So I know inulin is one of the exogenous filtration markers. So once you use it, then you are doing MGFR rather than eGFR. But in my comparison, probably if I go to the slide that I shared, almost the paper that discussed the performance, probably allow me to just project that slide. I don't remember which slide it was. It's just a minute. Yeah, I think you can see that slide. Sorry. You can see this one was measured eGFR. So I don't remember if they used inulin, but you can see the performance in terms of accuracy when they compared eGFR cystatin C against within 30% of measured GFR. So you can see a combined formula of GFR, creatinine, cystatin C had an accuracy of 90%. So basically, I think that's how you can say the comparison of the two. Thank you.
Thank you so much. Okay. Is the estimated GFR affected with physiological factors like dehydration? From Mark Karaoke. Thank you, Mark.
Mark,
and
thank
then,
you. I think.
Let me just add one.
Okay, sure.
Anonymous attendee, elaborate more on vitamin D or the kidney issue. Okay.
Yeah, thank you. I think somebody asked if physiological affect eGFR. Of course, if the physiology affects the marker, if the physiology affects creatinine, then of course it will affect the GFR. So indirectly it does because of affecting the marker. The last question you've just asked is about, sorry, you just skipped me.
Vitamin D or kidney
Oh,
issue.
vitamin D. It's because vitamin D is the active site where actually hydroxylation of vitamin D is happening to make it active. So if your kidney function is low, then you don't have an opportunity to activate your vitamin D. So of course, depending on what your methodology is measuring, so your vitamin D will be low. It's expected that your vitamin D should be low, expected. Thank you.
Thank you. This is from Bernard Corrier. Great presentation, Peter. How does sepsis affect creatinine? And if it affects, what could be its impact on the patient safety, especially those diagnosed with AKI?
I've not interacted with literature that has investigated sepsis versus serum creatinine. So I cannot really say if it affects serum creatinine. Probably, I don't know if because of the drugs, or maybe it could translate to analytical and not physiological. So that needs to be investigated differently, whether analytically a serum or a blood sample from a patient suffering from sepsis is affected, the creatinine is affected probably. But I can't really tell if I've interacted with any literature that tells me the effect of sepsis authoritatively to say that we are putting these patients at risk. So I might not be in a position to give a direct answer to that. Probably we also need to go back and look at what the literature says. Thank you.
Zuha Ladak, the GFR used is based on CKD API or MDRD. Which one is preferred?
MDRD, thank you. MDRD was one of the initial formulas, but the most recent one is CKD AP 2021. That is the one that, as you can see even here, the MDRD, I think, was in 1999, 2000, and 2006. That's when we were using MDRD. But we've shifted, like now we are having the CKD AP 2021 formula. Yeah, that's what we are currently using. When you look at this diagram, the journey that we've traveled here.
Thank you. Okay, this is from Alfred Kipkurui. Does diabetes have an impact on the kidney disease biomarkers? And then Janet Juma, to our diabetes and high blood pressure patients, how often are we supposed to perform renal function tests? Okay.
Diabetes. Okay, diabetes is a risk factor to kidney disease. So it doesn't affect markers per se, but it's a risk. So meaning you have to do a very close monitoring. I don't know, for the second question, I really can't say what is the interval, but basically from what I know is if you have, if your diabetes is well controlled, then you would space it, but if it is not well controlled, then you would do the monitoring closely. And I think in the World Kidney Day advocacy for this year, it was well captured. As you can see there, that blood test is usually glycated hemoglobin or fasting glucose to check for type 2. So if you have a well-controlled diabetes, I think clinicians will always space the number of times you do the test. But if you have uncontrolled diabetes, then we monitor it so closely because of the risk associated. Likewise for hypertension. So that will be more of clinical side, but it will depend on how well those two conditions are managed. Yeah, thank you.
Okay. Yeah, I'm just reading a question, but I'm seeing our senior Bosco has responded to it. So I think there's someone who asked there that why I was asking why kidney transplant patient are not allowed to donate blood, and when should they be allowed to? I can see Bosco has answered that. So, Peter, if you can allow me, there's a question that has come up, not necessarily here, but I think there's a national forum for MLTs, and there's a question that was asked, and maybe I can bring it on this forum so that maybe you can give us your insight, and maybe I can just read. A pregnant woman at her 40th week with a low protein level of 24 grams per liter and albumin 29.4 grams per liter. All controls and calibration done and passed. Other LFTs parameters normal except the raised ALP. Urinalysis is normal. What do members say about the total protein? I think the issue here is that the albumin was more than the total protein. So if you have anything towards this, Peter.
Yeah, I think it's a good case study, I say, because what we are getting here is the only clinical information that we have with this patient is 40 weeks, which I think this is term pregnancy. That is first thing that I note from that. And then the two things is because you said total protein is at what level? What is the total protein?
I think what
I know you said albumin is 24, which is very low.
yes.
So what was the total protein?
Low protein 24.
That is albumin.
Or albumin 29.4.
Or 29.4 and okay. So okay, my first thing that I would have thought of this, because he said the urine parameters were okay, I thought it would be preeclampsia, because we would expect that he's passing a lot of proteins in urine. But if the urine is not showing any traces of proteins, then I think this is something that we need to investigate the method. I don't know which method they were using. I know these two analytes are rather stable. They are very stable because total protein, but again, we need to see. I know they've already said that calibrations were okay, controls were okay, but do we have any other random thing? Was this run done once, or there was a repeated run for these two parameters? I don't know. So from the analytical side, we have to really check what might have happened, and also, do we have any previous test for this patient so that we can compare that we did maybe in day one, this was the value. We've repeated 2 days or 3 days later, this is the value. So do we have anywhere to compare, or it's the first time we are interacting with this patient? So I think this case is a case study, and case studies are usually very well when we take the clinical history of this patient, we go stepwise, we eliminate any analytical interference, then we correlate all these things and it might lead us to somewhere else. So for me, I think it's looking at the broader picture and not just look at what is shouting at us, which is the protein more than the albumin. So for me, I think we need to have the whole picture of the story. Do we have any previous test done? But I think someone else can air in because, of course, that is what I see. But I know we have colleagues here who probably might have interacted with such a case, and probably they might have an answer. But that would be my take for now. Thank you.
Leonard, I saw Leonard around. I saw him trying to attempt. Leonard, are you able to speak? You can just unmute and speak. Senior Leonard.
Thank you very much. Are you able to get me?
Yes, yes.
Yes, that case, somebody had asked in the MLS wall and had given some insight there. That one, in clinical chemistry, most of the time people have a lot of challenges, and these challenges arise from the fact that tests are based on specific principles. And when you have tests which end up with color formation or spectrophotometry, like happens in albumin, total protein, where you end up with a blue color, I think that's by that method, ECG or albumin method. So when you end up with such a color, normally it's good to go back because it's not possible. Just the fact that you feel out that it's not possible to have albumin because the last albumin is for physiological. If you have a part of immunoglobulin, also called globulin, so albumin plus globulin gives it for protein. So it's either if you have inflammatory disease where globulin, immunoglobulin is not adequate to produce reagents, then you can have very good proportionate levels. But here the case where the total protein is said to be less than this is not expected. So in this case, the only thing that one needs to know that due to the color formation, that's very high, that linear serum was bypassed. When you bypass the linear serum,
the equipment will give you any color that is available. So you go back to find out what are the medication the patient is on, which could probably interfere with the pH of that plasma which you have got or serum which you have got. So the test is not achieving its intended purpose. What it is doing is now it's just a reaction, but only one parameter is actually giving you the truth. So you need to go back to the clinician to find out the medication the patient is on, what they've been going through, and what is likely to happen if you have that medicine in the blood or in the serum which you are using to run the test. How does it interfere with the principle? And I gave quite a number of examples in that other wall, and there are still many, many more. But of course, the space is short to go expounding on all of them. Thank you.
Thank you so much, Senior Leonard, for your insights. And thank you so much. I can read a couple more questions as we are just coming to an end. So there's a question from Marion Chepngeno. There's a rise in CKD cases in teens. What could be the contributing factor to this, if you have any insight? And then I'll read another question from, this is from Alfred Njima. Are there recognizable patterns in kidney function tests, such as cases where serum creatinine is elevated, but cystatin C is normal, or vice versa? Anything, Peter?
Yeah, I think is the question of why are we seeing more CKD in teenagers. I can't really tell because that is an epidemiological aspect of a study. But probably, I would say probably it's because of the lifestyle and probably because of use of other things. Because you also know non-conventional medicine is, we usually use non-conventional medicine where we use herbal medicine sometimes, and overdosing sometimes cause this. So probably it's an epidemiological thing which I cannot have a real grasp of to say that this is the data that we have and we feel that this is what is happening. But in generally, I think it's because of lifestyle. If there's any recognizable patterns in kidney function, ideally, most of the time you might have a normal creatinine and an increased cystatin C. And the reason why is that is because cystatin C is an early marker. It picks up early enough more than creatinine. So you can have high cystatin C, but a normal creatinine. But having high creatinine and cystatin C, based on the theoretical aspect of it, I don't think it should be possible, not unless there's other factors involved. But the picture that I would say is just that pattern. You might have high cystatin C, but low creatinine because of the rise and fall of these markers. Thank you.
Thank you so much, Peter. Maybe this could be our last one from Tobias Yatich. What's the difference between the albumin when doing urine dipstick and urine albumin that has been discussed under kidney biomarkers?
The basic difference is because the one for urine strip is qualitative, this other one is quantitative. So that is the main difference. Of course, we also look at the sensitivity of the two. One is more specific than the other one. Yeah, so basically it's because this other one quantifies, this other one is very qualitative. Yeah.
Thank you so much. So I think, Peter, we've come to the very end. And as you can see, there are still many other concerns and questions, and very many people who have appreciated the presentation. And you have done a good job. Maybe I can just read this from Dr. Rachel Gidhiomi. She's saying, very nice PPT on kidney biomarkers. We are happy as your early mentors. Keep the fire burning. So thank you so much, Dr. Rachel, for tuning in. And at this point, we've come to the very end of this presentation. And I just want to take this opportunity to thank everyone who found time. I can see we were logged in, many of us from across the country. And I'm hoping that we have been able to learn something. So at this point, I want to give it back to Peter to say his closing remarks.
Thank you so much. I've seen my senior Bosco had raised his hand. I don't know if there's anything he needed to say before I close.
All right.
Yeah.
Bosco, you can unmute. I didn't see that. Sorry for that.
Hello, are you getting me?
Yes,
Yes.
we can hear you.
Yes, what I wanted to say about the protein in urine and the one we have discussed, which Peter has presented, is that when you have albumin in the urine, we call it overt proteinuria. It means that it is capable of passing through the glomerular membrane. But routinely, albumin should not be able to cross the glomerular membrane. So when it starts showing up in the urine, it is very overt, which means that's very obvious. You can pick the dipstick. But if you are going to get what we call urinary albumin-creatinine ratio, the one you are getting is called microalbuminuria. It means that it's the least that is leaking, but otherwise the one that you pick with the dipstick is what we call overt proteinuria or overt albuminuria. It's very obvious. It's already past, I think, 300 milligrams per DL. That's the one that you pick with your normal dipstick. But the one Peter is talking about is microalbuminuria. It is still the same in composition, but it is at a very micro level that if you are just measuring with a normal dipstick, you might not get any. It might be like a trace, which is very qualitative. Thank you. That's all I wanted to add.
Wonderful, Bosco, for that. That's great. I'm not sure the hands that are raised, if you want to speak, some were raised earlier, but let me just see if there's any new hand. So let me see if there's any new hand. Eric Adeng, do you want to speak? You can unmute and speak. Eric?
No, I don't have anything, please.
Okay. Mwarumba, do you want to say something? I can see you've raised your hand. Mwarumba? Lydia Mwamba? Mwarumba, you can speak. Unmute and proceed. Mwarumba? All right. Winnie Owino, do you want to say something? You can unmute and proceed. Winnie? All right. Isaac Koech, you can unmute and proceed. Isaac? Isaac? Malit Winnie, you can unmute and proceed. Malit? Malit Winnie? Okay, so I think most of the hands have been raised either by mistake. And so I can see a comment from Danny Mwanza. Urinary tissue inhibitor of metalloproteinases 2 and insulin-like growth factor binding protein 7 can also be used for early detection of AKI, but entirely cannot be used to replace GFR. Okay, thank you, Danny. So back to you, Peter.
this opportunity to have a conversation with my fellow colleagues across the country. It's always a pleasure to share and have these important discussions with one another so that we can improve, because the main goal here is to improve patient care, practice good science, and we achieve the goal of patient safety. So thank you, everyone. Thank you for the comments. Thank you for the accolades. Thank you for attending this session. I know it takes your time to attend such a session, and it gives us more strength to share more when people are attending these events. And we hopefully, I think this is the clarion call for me and all other presenters that present in this fora, that at least it changes one thing, or it reminds you of one or two things that you need to do in practice. Otherwise, I have nothing much. I'm just full of appreciations. I wish to thank all of you and wish you a fruitful weekend and a restful weekend. Yeah, thank you so much, and have a good evening.
Thank you so much, Peter, for that. And I also want to take this opportunity to thank everyone who found time to log in. I want to thank Peter for taking his time for preparing a very excellent presentation with references and all the materials that we need. And I'm glad to say that this presentation is live on YouTube. If at all you may want to listen to it again, you can go to LMSK YouTube and you can always watch it for your own future reference. I can see many concerns regarding those who are able to join through this Zoom and have not paid. No problem. You can always still contact us if you need the certificate or if you need the CPDs. You can always contact us after this so that we can be able to process for you. Otherwise, on behalf of Lab Medicine Society of Kenya, we want to take this opportunity to say thank you for always being with us and for always finding time to join into our webinars. Otherwise, I also want to take this chance to wish you a wonderful evening and a blessed weekend.